Hello everyone. I'm Dr. Masood Khan. Today our discussion is on Harrison Manual of Medicine. The topic of discussion today includes hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy results from a lack of delivery of oxygen to the brain because of extreme hypotension or respiratory failure. Most common causes are MI, cardiac arrest, shock, asphyxiation, paralysis of respiration, and carbon monoxide or cyanide poisoning. In some circumstances, hypoxemia may predominate. Carbon monoxide and cyanide poisoning are termed histotoxic hypoxemic because they cause a direct impairment of the respiratory chain. Clinical manifestations: mild degrees of pure hypoxemia, for example at high altitude, cause impaired judgment, inattentiveness, motor incoordination, and at times euphoria. However, with hypoxia ischemic or hypoxia associated with ischemia, such as occurs with circulatory arrest, consciousness is lost within seconds. If circulation is restored within 3 to 5 minutes, full recovery may occur, but with longer periods, permanent cerebral damage usually results. It may be difficult to recover even after 8 to 10 minutes of global ischemia. The distinction between poor hypoxemia and hypoxia ischemia is important because the partial pressure of oxygen as low as 2.7 kilopascal or 20 millimeter of mercury can be well tolerated if it develops gradually and normal blood pressure is maintained. But short durations of very low or absent cerebral circulation may result in permanent impairment. Clinical examination at different time points after an insult, especially cardiac arrest, helps to assess prognosis. The prognosis is better for patients with intact brain stem functions, as indicated by normal pupillary light responses, intact oculocephalic Dole's eye reflex, oculovestibular caloric reflex, and corneal reflexes. Absence of these reflexes and the presence of persistently dilated pupils that do not react to light are grave prognostic signs. A low likelihood of a favorable outcome is suggested by the absence of a pupillary light reflex or an extensor or absent motor response to pain on day 3 following the injury. Bilateral absence of the cortical somatosensory evoked potentials SSEP in the first several days also conveys a poor prognosis, as does a very elevated serum level more than 33 microgram per liter of the biochemical marker neuron specific enolase NSE. Usefulness of somatosensory evoked potentials and neuron specific evoked enolase is often limited, difficult to obtain in a timely fashion, need for expert interpretation, and lack of standardization. Administration of mild hypothermia after cardiac arrest may change the time points when these clinical and electrophysiologic predictors become reliable in identifying patients with a very low likelihood of clinically meaningful recovery. Long term consequences include persistent coma or vegetative state, dementia, visual agnosia, Parkinsonism, chorioathetosis, ataxia, myoclonus, seizures, and an amnestic state. Delayed post-anoxic encephalopathy is an uncommon phenomenon in which patients appear to make an initial recovery following an insult and then have a relapse with a progressive course often characterized by widespread demyelination on imaging studies. That is post-anoxic encephalopathy. Now, treatment of hypoxic ischemic encephalopathy. Initial treatment is directed at restoring normal cardiorespiratory functions. This includes securing a clear airway, ensuring adequate oxygenation and ventilation, and restoring cerebral perfusion, whether by cardiopulmonary resuscitation, fluids, pressors, or cardiac pacing. Mild hypothermia, that is at 33 degrees centigrade or 91 Fahrenheit, initiated as early as possible and continued for 12 to 24 hours, may improve outcome in patients who remain comatose after cardiac arrest. Based on trials in patients whose initial rhythm was primarily ventricular fibrillation or pulseless VT. Potential complications include coagulopathy and an increased risk of infection. Anticonvulsants are not usually given prophylactically but may be used to control seizures. Post-hypoxic myoclonus can be controlled with clonazepam 1.5 to 10 mg per day or valproate 300 to 1200 mg per day in divided doses. Myoclonic status epilepticus within 24 hours after a hypoxic ischemic insult portends a very poor prognosis even if seizures are controlled. Myoclonic status epilepticus within 24 hours after a hypoxic ischemic insult portends a very poor prognosis even if seizures are controlled. Thank you very much.